the heart goes into an arrhythmia. More importantly, if he had remained under general anesthesia for a long time, then he's at increased risk for a cardiac event on the operating theater. So a new procedure that is now being pioneered was done on this individual. My reason for telling you this is that let us all be aware that when these diagnoses are made, it is not made in a vacuum to say, let's control the sugar, the pressure, and the cholesterol. It is made for us to prevent end organ damage. And collectively, if we bring everything down to normal levels, increase our exercise, maintain our body weight, decrease and discontinue smoking and alcoholism, increase the amount of exercise and decrease your stress, you can actually prolong your existence and prevent end organ damage from your heart, your eyes, and your kidneys. Continue our discussion on my good friend with the coronary artery bypass graft that became totally occluded after 8 to 9 years, and I was faced with an increased risk of a massive cardiac event, and now totally unstable to have a normal procedure done, which is probably the open heart bypass again, and opening the sternum and opening the chest wall itself with a lot of scar tissue, which would take a very long time. So a new procedure, which was a robotic surgical procedure, was actually pioneered and was being done on this individual. The rationale behind it is that when you're faced with such an unstable patient, you have to minimize the time spent in the operating room and hopefully achieve a minimal result that will sustain life, continue to sustain life, and at the same time not expose the patient to increased cardiac risk by a prolonged surgery. When we imagine what the damages we do to our heart when the simple things like cholesterol, which have medications, tons of medications available to control it, the diabetes, which we can control so nicely with diet and exercise, and the high blood pressure by 1 or 2 medications per day. And to think about that, we could prolong our lives for many, many years and decrease the incidence of coronary artery disease, the heart attacks, the coronary events, and even the strokes that occur. And we can also decrease the damage, obviously, to our eyes and our kidneys. But we'll do that. We'll discuss that in another discussion. But when we ignore this little heart that sits in this chest wall, that supplies the entire body, your entire body depends on this little heart here, that supplies, that's sitting right in the chest wall here, that sends the blood supply to the brain, the blood supply to the arm, the blood supply to the chest wall, the blood supply to the abdomen, and the leg itself. We obviously know that we cannot be living without a heart that's pumping the amount of blood. When we get an echocardiogram, it tells us what the ejection fraction is, or the amount of blood that's being pumped out of the left ventricle. Because the left ventricle is the one that pumps the blood through the aorta, which is this big blood vessel that then sends it up to the neck itself through the carotid arteries, and also down the arms through the subclavian and the brachiocephalic arteries. Then posteriorly, it sends it down to the transverse aorta, then the thoracic aorta, and then the abdominal aorta, and then to the legs itself. Knowing fully well by doing an echocardiogram, and you see that the ejection fraction is decreasing, it means that the amount of blood that is being pumped by the left ventricle is not going to be enough to sustain it. We hope to have about 65%, and that is good enough to sustain normal activity. When you start approaching values of less than 50, then you start to worry. And how do you get those values? When we ignore our hypertension, diabetes, start to have decrease in blood supply, then we have damage to the cardiac muscle itself. And those are the things we face with. That's why it's so important to maintain the integrity of the blood supplies, the right coronary artery, the left anterior descending artery, the left circumflex artery. These are the ones that supply the heart with the blood. But you notice how narrow they are. So it's up to us not to try at all times to protect them. In my good friend's case, having had the bypass, now the bypass themselves became occluded because he ignored the fact that he had these disease processes and was never controlling them. Now, the minimally invasive procedure would have to be done through the chest wall itself. And this had to be done for people who are such great surgeons that sometimes you wonder if it were not for the medical care in United States by some of these brilliant personnel, some of us would not be alive. And my friend is someone in question who should not have been alive had it not been for this procedure. They went through the posterior aspect of the heart itself and then did the bypass, harvesting grafts from his legs as it is. The whole thing about it, without us not wanting to know what the whole procedure was about, is to see the events that took place. A young man who probably was not aware, because Guyana and the rest of the Caribbean doesn't focus as much on diseases that affect us. But when you face in the United States of 1.1 million persons will have a heart attack, out of 275 to 300 million persons, 1.1 of your population, which literally is probably around the region of 3 to 4%, will have a heart attack, first or second. And out of those, 1/3 will die of the heart attack. It makes us more important in this country, pay so much more attention to coronary artery disease. Not only is it a preventable disease and can actually be prevented totally or in an advanced stage of life, it costs an extraordinary amount of money. A lifetime supply of medication to control cholesterol, hypertension, and diabetes, no way pays for the amount of money that it costs the medical system to pay for coronary artery bypass graft or the care of a patient post-operative coronary artery bypass graft. Not only is it the increased morbidity and mortality, also a factor in the whole scenario, is the decreased life expectancy once a disease is advanced, is the decrease of performance in the work environment, the home environment of this particular individual. And here again, it is important for us who have these diseases to understand, by taking care of them, visiting your doctors, whoever your doctors are, and making sure that on a monthly basis at least, you know what the status of your sugar, your cholesterol, and also your blood pressures on a daily basis. And it's not difficult to do. You can chart this on a daily basis. How difficult it is to get up in the morning, stick your finger and see what your fasting blood sugar is. Less than 110, you're happy. Control your diet as you actually want to. Discontinue all sweets. You're actually able to take the half the amount or quarter the amount of carbohydrates. You don't need a plate of rice to be satisfied. You don't need 2 rotis to be satisfied. You don't need half a loaf of hot bread to be satisfied. You have to eat commensurate on the amount of energy you're going to be expending. And most of us are in clerical jobs. Most of us, we get home, we sit on the couch. So we do not expend a lot of energy, and we keep putting on more and more weight, but not understanding that it's not the weight that is the problem. It's the damage that's doing to your coronary arteries. It's the damage that's doing to your renal arteries. It's the damage that's doing to your cerebral arteries. All of that will cause you, and also the retinal arteries as well. And that is what is going to cause the end organ damage to your eyes, your heart, your kidney, and the brain itself. So it's so important for us not to go life the way that my friend did, from having known about the history, family history, not controlling it, having been told he had a cardiac event, ignoring that as well, had a bypass graft, ignore that as well, and then continue with a minimal invasive procedure. The good outcome of this, my good friend is alive and well, because the surgery was done by one of the most gifted surgeons. So my message here is that basically when you're faced with these issues, try the best you can to control it by diet, exercise, and medication, and get your families involved in your disease process. Continuing our discussion on common problems that I find in my family practice in Richmond Hill, Queens, and using this as a parameter to try and ascertain as best as I possibly can some of the things that are affecting our community. And when I see an increasing number of cases that are arising, it makes you wonder whether this is not just an isolated event, but seems to be a pattern of behavior. Many of the physicians who practice in the neighborhood share some of the same views, that is an increasing amount of drug abuse, starts up with marijuana and graduating up to things like heroin and cocaine, albeit not as large numbers as in some other communities. Early sexual activity which is a big problem, and group sex activity as well. Cigarette smoking, massive impact on the teenagers, and alcoholism being accepted at an earlier and earlier age in our homes. Some of these patterns of behavior is extremely disturbing because once it starts, it is extremely difficult to eradicate. It becomes accepted, and sometimes the only method of dealing with it is for the child to be removed from that school and the group of friends, or the family to relocate to another state where they can pay more attention to the kids, or maybe the environment is better. Case in question, over the last week, I've been seeing a patient and her parents for over about 6 or 7 years. The mother came with me with a request. Doctor, said, Dr. Bowel, I want you to examine my daughter, my teenage daughter, who is 15 years old, to see if she is sexually active. I was taken back by that particular request. For one, I felt that if I were the child, I would feel extremely alienated from my parent for having made a suggestion to a total stranger, albeit that stranger might have been the family physician for at least 6 or 7 years. The impact this creates on a child's mind is irreversible, because here you're asking for probably the most private of evaluation to be done in a very public setting. And it is not as if it's the first time this has been my experience. It has been asked time and time again. And I think if we address it as an issue, then maybe we can approach it differently. Rather than coming to the physician to say, Doctor, can you examine my daughter for premature sexual activity? Yes, there is a way of examining it to see whether or not the hymen is ruptured. But the hymen membrane, which protects the entrance into the vagina, can be ruptured from physical activity, can also be ruptured from foreign bodies insertion at an earlier age when you're a toddler, etc. It can also be damaged from other reasons as well, other than sexual intercourse. Now, the extrapolation of this is if I found, just for instance, I did the physical examination and I found that there was no hymen, do I conclude that this is sexual activity? And now, how then do I tell the mother that this is not really an indication that she was active? Now, if you find an intact hymen, what does that tell the mother? I told you so, I was not active. But the damage has already been done because you have a third party involved in this. Albeit it's a doctor who's qualified to do an examination. But I think the approach should be, if you suspect your teenage child of having sexual activity, your teenage daughter of having sexual activity, is to probably ask the physician in the presence of your daughter, my daughter is not performing well in school. She is not performing as well as she was doing before. She has an altered level of behavior that seems not to be acceptable by me. I wonder whether or not she has a new group of friends. I wonder whether or not she's actually involved in any activities, albeit cigarette smoking, marijuana abuse, or premature sexual activity. But I would like her to be tested for sexually transmitted diseases and to see whether or not she's using them. In that case, she could have addressed the issue with her daughter prior to coming to the doctor. I am not happy with what you're doing, and I do suspect that you may be having sexual activity, but I would like to make sure you're not at risk for any sexually transmitted disease. Then take the discussion a bit further, and then at least you keep the respect of your child intact in front of a stranger. The issue with this is that at all times the bond between a child and a parent should always be kept intact, even at the expense of embarrassing that child, even at the expense of you feeling that your hard work has been vindicated. Because you worked so hard, you obeyed your parents, doesn't mean that your child will do the same for you. But remember, the more damage you do to the relationship with your child, it's a more long-lasting defect. Sometimes at that age, you bring on a rebellious behavior pattern. So now instead, as I found out in a couple of cases when I actually discussed these matters, instead of having one partner with sexual activity, now that the parent has brought it to the fore, then they go about having multiple sexual partners. So what we did as parents, we actually escalated what was an issue of suspicion to now a behavior that now puts your daughter at extreme risk for STDs, worst of all, HIV. Worst of all, infertility. Because remember, what we're looking at here is she was asked me to do an examination to see whether or not the hymen in the vagina is there. But look at the bigger issues. If you are active, you infect not only the vagina, you infect the uterus, you infect the fallopian tubes, and eventually if the fallopian tubes becomes blocked, you will be unable to get pregnant. And I usually interpret that to mean, doctor, can you check my child to see whether or not they have an inflamed appendix? Because for all intents and purposes, for those of us who have never had abdominal surgery, we all have an appendix. The appendix is this vestigial structure that's at the distal end of the large bowel, the proximal end of the large bowel in the cecum. If you notice here where the small intestine joins the large intestine through that open the ileocecal valve, the distal end of it is where you find this appendage, which used to be important in the past, but is now not so important. When you look at the appendix itself, it's that little vestigial structure. It does nothing for you. It can have argentiferous cells, as our previous patient, and present with diarrhea. But it has a little valve, a little opening here, where you can get impacted stone from the stool or hardened stone. And when this happens, what it does, it occludes the blood supply from the appendix. The appendicular artery no longer is able to sustain the blood supply to an occluded area. It becomes inflamed, it becomes swollen, then it becomes gangrenous. When it becomes gangrenous, then it is no longer viable and it has to be removed. That is the process of an appendectomy. But how does the patient present? Usually is a healthy person who presents with anorexia, I don't feel like eating, with vague periumbilical pain. The pain is never the point where the appendix is. The pain is usually a periumbilical pain. The pain is around the central portion of the abdomen. Because when a part of the bowel becomes considered part of the midgut, so the pain from midgut radiates to the central portion of the abdomen, not to this area. So the patient will complain, I don't feel like eating, I feel unwell, I'm having periumbilical pain around the belly button. If this continues, then the pain radiates down to where the appendix is, and that's when the appendix is inflamed. The reason for the radiation of the pain is the inflamed appendix just irritates the peritoneal wall and now becomes localized to the area. At that point in time, any physician can diagnose an acute appendicitis. Just from the history, I feel unwell. I'm having a little bit of a fever. I feel anorexic. I had periumbilical pain, but now the pain seems to be shifting, and the pain seems to be shifting down to the right lower quadrant. That is assuming that that patient has the classic appendix in that position. But we all know that the appendix can vary in position depending on what is happening with the large bowel. So you can even have pain if the appendix is located over here. The bowel is everted on the other side, not transversus, but everted on the higher up. You can actually have it mimic gallbladder pain. But those are rare occasions. In fact, if you look at this diagram, there's so many places that you can actually have your appendix located that sometimes it is difficult to make the diagnosis if it's atypical, but very easy to make the diagnosis. These are all the different positions that you can find in the appendix, but basically very, very easy to make the diagnosis. Periumbilical pain radiated to it. When you examine the abdomen, and a generalized examination of the abdomen will reveal diffuse tenderness around over the abdomen. But when you examine the appendix, which you can actually locate, the base of the appendix is located 1/3 of the way from the anterior superior iliac crest to the umbilicus. And you basically, at that point, is very tender, where the patient literally wants to jump up from the bed. You would obviously deal with an inflamed appendix, and the base of the appendix is inflamed, and there's where the diagnosis is made. Sometimes having made a diagnosis is not to give a painkiller, because you want the surgeon, when he examines the abdomen, to actually be able to palpate and ascertain for themselves what the degree of pain is. It's kind of sometimes considered cruel, but it's not cruel. It's to alleviate, to be able to make the proper diagnosis. Because suppose you give something for pain, then the surgeon comes along and not able to elucidate the same findings that you were able to do because the patient did not have any analgesic. What is done at that point in time, the person is admitted to the hospital, an intravenous line is set up. Sometimes rehydration helps tremendously with that person. And then evaluate the degree of the pain, whether the intensity and the severity of the pain is increasing. What you try and avoid at all costs is for an appendix to rupture because you are tardy in either getting to the physician, or the surgeon is tardy in terms of making the diagnosis. And that appendix, which was gangrenous, no, that appendix ruptures. So you just imagine if this appendix here becomes inflamed, it ruptures. What now happens is that stool from the large gut spreads throughout the peritoneal cavity. So the distal end of the appendix here, now you have stool in the appendix. Now you have a peritonitis. When you have a peritonitis, not only can you not make that small incision to just take the appendix out, with digital you can do it, take the appendix out and remove it at the base with a very small incision. If you have a ruptured appendix, you have to make an incisional scar throughout the abdomen, to the entire abdomen, through the umbilicus, and irrigate the bowel. Because in that case now, you're going to be left with an inflammation in the large bowel, which in itself will only lead to further problems in the future. And what are the major problems in the future? The major problem is having gone into an infected bowel, you are going to be left with scar tissue. Now you're faced with having gotten into the abdomen, you cut into the abdomen, not the small scar here, but you've cut into the abdomen, you've opened up the abdominal muscles, you've opened up the peritoneum to get to the appendix there, irrigating it, washing it out to get rid of as much stool as possible. But that in itself, because of the infective nature of it, not only have you done something that's going to be causing the patient more morbidity and mortality in the future, you've left a bigger scar in the abdomen, but the worst sequelae of it is adhesions, which are these small fibrous bands that form from the gut itself to the abdominal wall, the internal abdominal wall, and that itself can cause abdominal obstruction at any time. I've seen many patients who've had ruptured appendix present to the emergency room at all times with intestinal obstruction, and it's a very, very serious thing to live with, because once you start to have intestinal obstruction, which means that the bowel becomes blocked at some point, because you form these adhesions. When you form an adhesion, you occlude the passage of fluid from proximally to distally. And if this occurs on a regular basis, the patient complains of abdominal pain, bloating, not being able to pass gas at a later stage, and now starts to vomit. That means hospitalization, drip and suck if it doesn't settle. Drip and suck meaning putting a nasogastric tube to decompress the bowel and an intravenous line, and basically to rehydrate. If it doesn't settle, it means another operation. So every increasing operation will result in further scar tissue. So at all times, in abdominal pain, you must be seen by your physician. If you have abdominal pain that starts in the periumbilical region, radiates to the right lower quadrant, definitely your first diagnosis has to be an inflamed appendix. And at all costs, have the evaluation done. Even if the appendix was not inflamed to the point of being edematous to rupture, remove it, because it's not even needed. But it prevents another source of pathology in the future.